Now let's go. Okay. So for your board exams, remember that not every pulmonary edema is because of left-sided heart failure. You know, the commonest cause of pulmonary edema is left-sided heart failure. We know that we've been saying that for a long time, right? But today in the class, you realize that if you want to ace a case on pulmonary edema, you must know what are the causes of pulmonary edema, what are the non-cardiac causes of pulmonary edema as well. And this is very, very important. So we're going to try some questions like we do to help us to break the concepts down very well. So I have a first question for you. You have a 68-year-old with long-standing hypertension who develops abrupt severe dyspnea at rest. The blood pressure is 220 over 120 millimeters of mercury. New tachyarrhythmia at 160 beats per minute. Bibasilar crackles. Pink frothy sputum. Now, he did a portable echocardiogram which shows concentric left ventricular hypertrophy. Valves are not clearly visualized. Which mechanism best explains his pulmonary edema? Which mechanism best explains the patient's pulmonary edema? A, marked increase in alveolar capillary permeability with normal wedge pressure. B, acute rise in left-sided intracardiac filling pressure, causing hydrostatic transudation. C, reduced plasma oncotic pressure, increasing net filtration. D, redistribution of pulmonary blood flow due to microthrombi. And E, primary right ventricular failure with low left-sided pressure. So what's the correct answer here? I see Dr. AB going for B. Dr. Saravana is also going for B. And the correct answer is B. So the way the patient presented, let me take you back. 68-year-old a patient with long-standing hypertension develops abrupt severe dyspnea at rest. This is what we call flash pulmonary edema. It's very scary. The mortality rate is really, really high. Okay, so this is what we call flash pulmonary edema. And you have to learn the triggers of flash pulmonary edema. So please, one of the main triggers of flash pulmonary edema is hypertensive emergency. Okay, and at times the patient can also develop tachyarrhythmias like abnormal heart rhythm. And what this does is that it causes an abrupt increase in left-sided filling pressure, that the left side of the heart, that's the left ventricle, the left atrium, right? And then that leads to hydrostatic flooding. So please remember, how does a patient with flash pulmonary edema present? Usually the patient will present with abrupt pulmonary edema. And the predisposing factor is hypertensive emergency and a tachyarrhythmia. Okay, next question. You have a 61-year-old who presents with acute respiratory distress and diffuse bilateral opacities on chest X-ray. Echocardiogram shows normal left ventricular size and systolic function. No clear valvular abnormality. To distinguish cardiogenic from non-cardiogenic edema, which tests and results would most specifically support non-cardiogenic edema? A, elevated pulmonary capillary wedge pressure. B, normal pulmonary capillary wedge pressure. C, elevated central venous pressure. D, elevated brain natriuretic peptide, BNP. And E, atrial hypoxemia. Correct, Dr. Rockefeller. Correct. So which to distinguish cardiogenic from non-cardiogenic edema, pulmonary edema, which test and result would most specifically support non-cardiogenic edema? So, in other words, how do you separate non-cardiogenic edema from edema? How do you distinguish between the two of them? So I see a lot of doctors also going for B. So why is B correct? Non-cardiogenic pulmonary edema occurs without elevated wedge pressure. So in your board exam, if you see a case of pulmonary edema and you are told that the wedge pressure is normal, that means that the kind of pulmonary edema the patient has is non-cardiogenic. Now, in cardiogenic pulmonary edema, there will be elevated wedge pressure. So please put this in your mind and write it down, because at the end of the class, I'll be doing the active recall lessons as well. Okay? Elevated wedge pressure favors cardiogenic pulmonary edema, and normal wedge pressure favors non-cardiogenic pulmonary edema. Okay? Okay, good. I have another question for you. A patient has acute diffuse alveolar infiltrates and hypoxemia. Echocardiogram is unremarkable. There is no clinical evidence of acute hypertension, ischemia, tachyarrhythmia, valvular obstruction, fluid overload, or renal failure. Which pathophysiologic statement best fits non-cardiogenic pulmonary edema? A, it is due to elevated left atrial pressure more than 15 millimeters of mercury. B, it reflects increased capillary permeability with wedge pressure not elevated. C, it requires underlying coronary artery disease. D, it cannot cause diffuse alveolar filling. And E, it is defined by reduced right-sided pressures. What's the correct answer? What's the correct answer for this particular question? Is it A? Is it B? Is it C? Or is it D? So I see quite a number of doctors going for B. I see others going for E as well. And the correct answer is B. Okay? Because non-cardiogenic pulmonary edema is caused by permeability mediated alveolar fluid accumulation. So the alveoli become permeable to, whatever is causing the pulmonary edema. And that is why the patient develops pulmonary edema. Meanwhile, the cardiogenic pulmonary edema, it's as a result of changes in pressure. So that is what you have to understand, the two. So now let's do a deep dive. Cardiogenic versus non-cardiogenic pulmonary edema. Cardiogenic versus non-cardiogenic pulmonary edema. There are some differences and there are some similarities. Two similarities are that, number one, both, so if you have one patient with cardiogenic pulmonary edema and the other patient with non-cardiogenic pulmonary edema, both of them will present with dyspnea. Both of them will present with dyspnea. Number two, both patients with cardiogenic and non-cardiogenic pulmonary edema will have fluid in the alveoli. Both of them will present with dyspnea, shortness of breath. Both of them, when you listen to their lungs, you will hear crackles. Okay? Now, what is the key difference? The key difference is the pressure behind the alveolar edema. we learned that in cardiogenic pulmonary edema, the wedge pressure will be high. In non-cardiogenic pulmonary edema, the wedge pressure will be normal. So the difference is that in cardiogenic, there's pressure which is pushing the fluid, right? So it increases left-sided filling pressure. Therefore, there's hydrostatic overflow. And I'm going to use a sponge to explain it. So Dr. Reka says, but we'll have elevated wedge pressure in cardiogenic pulmonary edema. Yes, there will be elevated wedge pressure in cardiogenic pulmonary edema. And in non-cardiogenic pulmonary edema, the pulmonary edema is occurring not because of increased pressure per se, but because the alveoli have become porous and there's permeability in the leakage. So think about it this way. Think about this. All of us wash bowls at home, right? And there is this sponge. There's a sponge. Just think about it. There's a sponge. Consider the sponge as your lung or the lung of the patient. Now, what is cardiogenic pulmonary edema? In cardiogenic pulmonary edema, you've opened the tap. The water is flowing. It's flowing. It's flowing. It's flowing. It gets to a point in time that the sponge can no longer hold the water. And because of that, the fluid spills into the sink. Why? So that means that the pressure is too much. That is how I want you to think about it. The water flowed. And so the sink just gets flooded. But with a non-cardiogenic pulmonary edema, the sponge is torn. And so it is leaking. And because of that, any little amount of fluid you put through, it sinks into the sink. Doctors, please, does this make sense? I want to know. Does this make sense? Think about the sponge. So the sponge is the lung. For cardiogenic pulmonary edema, you open the tap, and because of that, the sponge got flooded, and then it spilled into the sink. But for non-cardiogenic pulmonary edema, there were holes in the sponge. And so the little amount of fluid which came in, boom, it spilled. So one is as a result, so in both cases, there's spillage of fluid, but one of them is as a result of excessive pressure. The other one is as a result of seeping fluid through the pores of the alveoli. And that is why one comes with elevated wedge pressure and the other one comes with non-elevated wedge pressure. Another definition we need to know, and we talked about it when we're solving the first question, is flash pulmonary edema. In flash pulmonary edema, you realize that there's a dramatic, sudden cardiogenic alveolar flooding from abrupt surge in left-sided filling pressure. So it is sudden. And what are the causes of flash pulmonary edema? The causes of flash pulmonary edema are, number one, if the patient develops hypertensive emergency, number one. Number two, if there's acute ischemia, maybe a myocardial infarction. Number three, if there is new tachyarrhythmia. And number four, if there is an obstructive valvular disease. These are the four common causes of flash pulmonary edema. Doctors, please, this one, I need you to write it down. Write this down. What are the common causes of flash pulmonary edema? Hypertensive emergency. Number two, acute ischemia. Number three, new tachyarrhythmia. Number four, obstructive valvular disease. These concepts are a bit, specific, so that's why I'm taking my time. So doctors, please know the difference between cardiogenic and non-cardiogenic pulmonary edema. Know what flash pulmonary edema is. Know the causes of flash pulmonary edema. Let me move on. This one, we've already talked about it, how to tell the difference between cardiogenic and non-cardiogenic pulmonary edema. So you realize that in cardiogenic pulmonary edema, because it is coming because of the pressure, right? Because of the hydrostatic pressure in pulmonary capillaries, it's as a result of transudates into the interstitial, But in non-cardiogenic pulmonary edema, there's increased permeability of the alveoli, Therefore, the kind of fluid you find there is protein rich. While cardiogenic pulmonary edema is as a result of transudate, most of the time in non-cardiogenic pulmonary edema, it's as a result of an exudate. And in cardiogenic pulmonary edema, the wedge pressure is elevated. In non-cardiogenic pulmonary edema, the wedge pressure is normal. So we are building it gradually. Dr. Rockefeller, are you with me? Are you with me? Everyone, please, doctors, are you with me with the points I'm raising? Because we need to understand these for our board exam. All right? Okay, good. So, how to tell the difference between cardiogenic and non-cardiogenic pulmonary edema again? So, you have to look at the history. The dyspnea onset. What were the precipitants? Was the precipitant more of hypertension? Did the patient complain of chest pain? Did the patient complain of lightheadedness and heart racing? Was there any clue of volume overload? Another thing you can use to differentiate between them is echocardiography. You want to check the cardiac function. You want to check the valves. And then you also want to do laboratory analysis. And then you want to also measure the pulmonary capillary wedge pressure. Because in cardiogenic pulmonary edema, the pulmonary capillary wedge pressure is elevated. But in non-cardiogenic pulmonary edema, the pulmonary capillary wedge pressure is normal. So these are the things you want to start looking at in a question stem to help you to tell, is this cardiogenic pulmonary edema or non-cardiogenic pulmonary edema? So we've been talking about pulmonary capillary wedge pressure, pulmonary capillary wedge pressure, pulmonary capillary wedge pressure. What does it mean? It is the pressure inside the left side of the heart, especially the left atrium. So when I'm saying pulmonary capillary wedge pressure, pulmonary capillary wedge pressure, pulmonary capillary wedge pressure, what I mean is the pressure which is in the left atrium. How much pressure is backing up into the lungs? Don't forget that the left atrium receives blood from the lungs, oxygenated blood, and then it will open up into the left ventricle, and the left ventricle will pump it to the rest of the body, right? So if the pressure in the left atrium is high, that means the blood is going to back up and it's going to affect the pressure in the lungs. And that is why the patients will develop pulmonary edema. Well, there's a lot with the pathophysiology, which will go into renin-angiotensin system and all those things, but I don't want to bore you with all that. So why pulmonary capillary wedge pressure is important? Why is it important? Especially in left-sided heart failure. So think about it, especially in left-sided heart failure, if the left ventricle cannot pump well. So think about it, left ventricle cannot pump well. There's blood is coming from the left side, the lung, it comes to the left atrium, then the valves will open so that the blood will go to the left ventricle, and the left ventricle will push the blood to the rest of the body. Now, just think about it. If you have a patient who has left ventricular issues, that would mean that pressure is building in the left ventricle. And if pressure is building in the left ventricle, that pressure is going to be transmitted into the left atrium. And if that pressure is transmitted into the left atrium, guess what is going to happen? Then pressure is also going to build in the lung through the pulmonary veins. And that is what is going to lead to pulmonary edema. Doctors, please, does that make sense? I want to know, does that make sense? Just think about the left side of the lung, the left side of the heart. The left side of the heart has the left atrium, and then the valves will open, and then we get the left ventricle. But before the blood gets into the left atrium, it comes from the lung, oxygenated blood. Now, just think about something which is backing up. Assuming the left side, the left ventricle does not work well, what is going to happen? It's going to affect the left atrium, which supplies it with blood. And if the left atrium, the pressure in the left atrium is also affected, then it's going to back up into the lung, which is supplying the left atrium with oxygenated blood. That is it. So this picture helps me to understand it. Just think about it. Deoxygenated blood goes into the lungs, and then the lung, I breathe in, and then I get oxygen, and because of that, that deoxygenated blood is then converted to oxygenated blood. Now, oxygenated blood has to come through the left atrium into the left ventricle, and the left ventricle will pump it to the rest of the body through the aorta. Now, assuming there is heart failure, and heart failure basically means that the left ventricle is not pumping well. So there's going to be a the pressure is going to be transmitted backwards, right? Because if the left atrium pumps, the blood should go through the aorta to the rest of the body. But then there's a problem with the left ventricle. So then there's going to be a buildup of pressure in the left ventricle, and that buildup of pressure is going to build up into the left atrium. And that left atrium pressure is then going to build up into the lungs. And therefore, that blood flow, which was supposed to be quick, now you realize that pulmonary edema starts developing. All right? That's what is going to happen. So, let's talk about the types of edema. Dr. Salgana has a question, but in a chronic condition, PCWP will be increased in pulmonary edema, isn't it? Yes, sure. Yeah, it's going to increase. It's going to increase. It's going to increase. Okay? Okay. So let's continue. Today's class, I'm taking my time. There's so much to do, but I'm taking my time so that we can get it very, very well. Okay? So the type of edema, cardiogenic pulmonary edema due to heart failure, there will be high PCWP. So that's what Dr. Salgana was asking about. And in non-cardiogenic pulmonary edema, there will be normal PCWP. Doctors, please, does this point make sense? I've emphasized this point over and over and over and over again. So let's move on to the next thing. So now let's focus on cardiogenic pulmonary edema. We've talked about the differences. Now let's focus on cardiogenic pulmonary edema. Let's try this question. A patient with known bilateral renal artery stenosis presents with recurrent sudden episodes of pulmonary edema requiring hospitalization. What is the name of this clinical association? In other words, what is the name we give to a patient who has bilateral renal artery stenosis, who then develops pulmonary edema as a result of the bilateral renal artery stenosis? A, Eaton-Lambert syndrome. B, Pickering syndrome. C, Korn syndrome. D, Takotsubo syndrome. And E, Eisenmenger syndrome. What's the correct answer? What's the correct answer? What's the correct answer? So I see Dr. Lamia says, I don't know. Sure, Dr. Lamia, that is why we have met here. So the correct answer is B, Pickering syndrome. So, but one thing I want you to know is for your board exam, please learn what Eaton-Lambert syndrome is, learn what Korn syndrome is, learn what Takotsubo syndrome is, and learn what Eisenmenger syndrome is. But the correct answer is B, Pickering syndrome, right? Pickering syndrome basically is you have a patient who has bilateral renal artery stenosis, and then that patient develops recurrent flash pulmonary edema. That's Pickering syndrome. Pickering syndrome, please. Remember, Pickering syndrome. That is what Pickering syndrome is all about. Okay? All right. Let's go to the next question. Let's go to the next question. Which trigger can cause pulmonary edema even if the patient has mild or no chronic heart disease? Which trigger can cause pulmonary edema even if the patient has mild or no chronic heart disease? A, hypertensive emergency. B, mild anemia. C, controlled asthma. D, iron deficiency. And E, hypothyroidism. What's the correct answer? What's the correct answer? What's the correct answer, doctors? Sure, I see a lot of you going for A. Dr. Rockefeller, you got that right. Dr. Sorgana, you got that right. So hypertensive crisis alone can generate enough afterload to cause edema despite normal ejection fraction. Okay, so cardiogenic pulmonary edema, it occurs when left-sided cardiac filling pressures acutely rise and it pushes the fluid from the pulmonary capillaries into the interstitial and alveolar spaces. I've explained this in the previous slide. Now, know the differences between predisposing and precipitating factors of cardiogenic pulmonary edema. Okay, know the differences between predisposing and precipitating factors of cardiogenic pulmonary edema. So, what are the predisposing factors? Predisposing conditions are chronic cardiac problems that set the stage for future pulmonary edema. So, these are underlying, so it's like, these are underlying conditions which set the stage for future pulmonary edema. Someone says I should go to the previous slide. So, Dr. Rockefeller, this is the previous slide. You've got to know the differences between predisposing and precipitating factors of cardiogenic pulmonary edema. Okay, so predisposing factors are things which set the stage, and then precipitating factors are things which cause the thing to happen. So just think about a gun, right? Predisposing factors are the fact that the gun is loaded with a bullet. Precipitating factors are the fact that someone picks the gun and actually shoots the gun. That is the difference. That's the difference. Predisposing factors, they set the stage. Precipitating factors, they shoot the bullet. Okay, so causes of cardiogenic pulmonary edema: coronary heart disease, hypertension, valvular heart disease. You can also have patients with idiopathic dilated cardiomyopathy. You can also have patients who are even taking, toxins like anthracyclines, metabolic issues like hypothyroidism, viral myocarditis like Coxsackie B and echovirus. These ones, you just have to know them rote memorization. Okay, causes of cardiogenic pulmonary edema, that is systolic dysfunction, conditions which will cause the heart not to be able to pump blood to the rest of the body well. Systole. Now, we also have diastolic dysfunction. So diastolic dysfunction is the fact that what are causes of cardiogenic pulmonary edema as a result of the fact that the heart cannot relax. That is diastole. Systole is the heart is pumping. Diastole is the heart is relaxing, right? So just think about conditions that can cause the heart's ventricle to be stiff, or the fact that the heart cannot relax well. And because of that, it impairs filling, right? Both of them. If there is impaired filling or there is decreased ability to pump, all of them can cause pulmonary edema. Okay, so just think about, take your time and break it down. That's why I love breaking concepts down in these classes. Okay, so diastolic dysfunction can be caused by left ventricular hypertrophy. The left ventricle is so hypertrophied that it is not able to give room for the blood to come from the left atrium. Number 2, hypertrophic cardiomyopathy. Number 3, restrictive cardiomyopathy. Number 4, acute ischemia. Number 5, acute hypertensive crisis. Number 6, exacerbating factors like concurrent systolic dysfunction, subendocardial ischemia, and arrhythmias. Because in arrhythmias, the heart does not get the time to actually pump well and relax well. So that is where the problem can come from. Then there is another cause, left ventricular outflow obstruction. So can you imagine that the left ventricle is trying to pump, but then there's a blockage of that aortic valve. So it's building pressure. So the left ventricle is normal, but then the aortic valve is stiff. So you see, we are looking at all the various things. Okay, there's a problem with the left ventricle itself. It can lead to cardiogenic pulmonary edema. There's a problem with the left ventricle relaxing. It can cause that. Now, the left ventricle is normal, but when it is trying to pump, the blood is going against that aortic valve. And that also increases pressure in the left ventricle. That is it. So, if the patient has aortic stenosis, which is very critical, or hypertrophic cardiomyopathy, or systemic hypertension, severe systemic hypertension. So, the left ventricle is trying to push, but the pressure in the systemic vessels causes that pressure to back up. And then that pressure is transmitted into the left ventricle. It is transmitted into the left atrium. Now it is transmitted to the lungs. So you see, it's all about thinking about first principles. Yeah, so Dr. Kanika, tamponade will be part of the diastolic dysfunction, right? Because the tamponade is restricting the heart. So it is part of the diastolic dysfunction. Okay, good. Now, there can also be mitral stenosis. So mitral stenosis is the mitral valve, that valve which has to open for the blood to flow from the left atrium to the left ventricle. So it will cause pressure to be backed up into the lung and cause the pulmonary edema as well. So rheumatic heart disease, mitral annular calcification, bioprosthetic valve dysfunction, okay? And the left atrium will become non-compliant. And with tachycardia, there's decreased diastolic filling, and there's an abrupt spike in the left atrial pressure, and that will lead to pulmonary edema. Okay, so just think about it. Blood flow from the lung to the pulmonary vessels through the left atrium. After the left atrium, it has to go through the mitral valve. So if there's a problem with the mitral valve, there can be pressure buildup. Then from the mitral valve, the blood will flow into the left ventricle. If there's a problem with the left ventricle, either that the left ventricle is failing or the left ventricle cannot relax. There's a problem. Now, what if the left ventricle is normal, but the vessel, the valve it has to pump the blood through to the rest of the body, the aortic valve, is also problematic. So all these things, if you just trace it, you realize that it is easy peasy for you in the exam. And then we also learned about the renovascular issue, where we talked about the Pickering syndrome, right? So you have a patient who has bilateral renal artery stenosis. And that leads to a whole pathophysiology thing I don't want to get into, but just get this into your mind. Bilateral renal artery stenosis with flash pulmonary edema, think about Pickering syndrome. Okay, good. And then what are the precipitating factors? So we looked at all the predisposing factors. Now let's look at the precipitating factors. Hypertensive emergency, acute ischemia, okay, new tachyarrhythmia, obstructive valvular disease, primary fluid overload. So maybe the patient is in the hospital, the patient is receiving IV fluids, and the patient has been overloaded with fluids, okay? And then severe renal disease, as well as renal artery stenosis. Okay, let's move on. So what is the end result of cardiogenic pulmonary edema? You realize that there's high left ventricular filling pressure, and because of that, there's fluid retention. And because of that fluid retention, thinking from first principles, that will lead to pulmonary edema. Simple as that. We are working backwards. Now, let's talk about non-cardiogenic pulmonary edema. But before that, doctors, please, the cardiogenic pulmonary edema, did it make sense? All the things we talked about, did it make sense? If it didn't make sense, I'll stop the class here. Did it make sense, please? Did it make sense? Before we go to the non-cardiogenic pulmonary edema, the cardiogenic pulmonary edema, did it make sense? Yes or no? And so in your board exam, if you get a patient with cardiogenic pulmonary edema, you should be able to manage it very well. Okay? You should be able to manage that case very well. Okay, so now let's talk about the non-cardiogenic pulmonary edema. The non-cardiogenic pulmonary edema is pulmonary edema which is caused by increased capillary permeability, where there's fluid leaking into the alveoli, not because there's elevation in the left-sided heart pressure. No, fluid is just leaking into the alveoli. And remember the sponge analogy that we did, the sponge in the sink, right? So the main pathophysiology of non-cardiogenic pulmonary edema is that there's increased capillary permeability. The capillaries become too permeable. And because of that, there's protein-rich fluid which enters the alveoli. And because of that, there's impaired alveolar fluid clearance. And there's inflammation and injury to the capillary endothelium. And that even makes things worse. This is how non-cardiogenic pulmonary edema occurs. Now, for your board exam, always remember, common things are common. So if you don't remember anything at all, if you don't remember anything, remember that number one, non-cardiogenic pulmonary edema is exudative. Number two, the commonest cause of non-cardiogenic pulmonary edema is acute respiratory distress syndrome, ARDS. Simple. The commonest cause of non-cardiogenic pulmonary edema is ARDS, acute respiratory distress syndrome. Please, this one, the commonest cause, common things are common. Commonest cause of non-cardiogenic pulmonary edema is ARDS. Now, after we've done that, then we can look at the less common causes of non-cardiogenic pulmonary edema. So if you've not picked up the commonest cause, forget about the non-common causes. So first, even if you forget anything I'm teaching today, remember ARDS is the commonest cause of acute respiratory distress syndrome. What are the less common causes of non-cardiogenic pulmonary edema? Number one, neurogenic pulmonary edema. And what is neurogenic pulmonary edema? You have a patient who has head injury. After the head injury, the patient, you listen to the lungs, there's crackles. That is neurogenic pulmonary edema. You also have a patient who had a seizure. Just after the seizure, the patient develops bad pulmonary edema. That is what you call neurogenic pulmonary edema. Another one is a patient who has an intracranial bleed. And after the intracranial bleed, you listen to the lung, you realize that there's pulmonary edema all over. That is neurogenic pulmonary edema. Usually, neurogenic pulmonary edema, it is rapid in onset, and you see the infiltrates bilaterally. There is no cardiac failure. There's no heart failure in neurogenic pulmonary edema. The next one is high altitude pulmonary edema, HAPE. That is why I put the picture of the mountain there. So as the person is climbing the mountain, if they go above 3,000 to 4,000 meters above sea level, they develop severe hypoxia, they start coughing. Then when you do a chest x-ray, when they come down, you realize that they have patchy infiltrates. And usually, in high altitude pulmonary edema, unlike neurogenic pulmonary edema, where you see the bilateral infiltrates, in high altitude pulmonary edema, you see the infiltrates more on the right side of the lung, the right lung. Doctors, please, these are very, very, very important board exam concepts we are covering today. So neurogenic pulmonary edema, usually you see the infiltrates in both lungs. In high altitude pulmonary edema, you see the infiltrates on both lungs, but it has a predominance for the right lung. Doctors, please, can I move on? I beg you. I want to make sure that we are getting it before I move on. Can I move on? So if I present two patients, both of them have pulmonary edema, but for one of them, it is more common in the right. You should be able to tell me that it is more likely as a result of high altitude pulmonary edema. And then you have a patient who just had a seizure, and then you listen to the lungs and you can hear crackles in both lungs. You can tell that this is neurogenic pulmonary edema. Other causes of non-cardiogenic pulmonary edema are medications like opioids. So heroin, fentanyl, methadone, and naloxone. Doctors, by the way, while we are on this, please go make sure you're on the MedCognito YouTube channel and you have clicked and subscribed to the channel. And please give us some thumbs up, because today we are doing a very, 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 very good job. We are doing a very, very good job. So please give us a thumbs up, click on the like and the subscribe button on our YouTube channel. Okay, good. So opioids can cause non-cardiogenic pulmonary edema. Salicylates can cause non-cardiogenic pulmonary edema. Amiodarone can also cause non-cardiogenic pulmonary edema. You can have immunosuppressants like sirolimus and everolimus. These can also cause non-cardiogenic pulmonary edema. Patients who also vaping, patients who also use e-cigarettes, and patients who may be going for maybe a renal like contrast enhanced CT, and then they are giving some contrast agents that can also lead to non-cardiogenic pulmonary edema. And snake and scorpion venom can also lead to non-cardiogenic pulmonary edema. I'm just going through this because this one you just have to know. Okay, the other cause of non-cardiogenic pulmonary edema. The commonest cause of non-cardiogenic pulmonary edema is acute respiratory distress syndrome, right? If a patient hits the head and develops pulmonary edema, I'm going to think about neurogenic pulmonary edema. If the patient climbs a mountain and then develops pulmonary edema, I'm going to think about HAPE, high altitude pulmonary edema. And then other less common causes are medications, contrast dye, scorpion bite, snake bite. Other ones can be pulmonary embolism. And then a patient who gets blood transfusion, we call that TRALI, transfusion-related acute lung injury, TRALI. Okay, and then we also have people who can develop pulmonary veno-occlusive disease. For me, TRALI is the most important thing on this slide. So even when you are learning about transfusion reactions, TRALI also comes up, right? Good. So the other, miscellaneous causes like negative pressure edema, where a patient who has an endotracheal tube and bites on the tube, right? If a patient develops laryngospasm, the larynx spasm, okay? And then re-expansion pulmonary edema. So you have a patient who had maybe pleural effusion, and then you did thoracocentesis, and then you took the chest tube out, and then the patient develops crackles again. It can be what we call re-expansion pulmonary edema. Okay, and then there can also be capillary leak syndrome and uremic lung, like a patient who has chronic renal failure who develops a uremic lung. These are all miscellaneous causes, but don't forget your ARDS. Don't forget your HAPE. Don't forget your neurogenic pulmonary edema. Another thing you need to know, and don't be tricked in your board exam. You know that if a patient has hypoalbuminemia, that patient can have decreased oncotic pressure in the blood, right? Now, hypoalbuminemia on its own does not cause non-cardiogenic pulmonary edema. But if you have a patient with elevated hydrostatic pressure, hypoalbuminemia can worsen that. But hypoalbuminemia on its own will not cause it. But if the stage is set, then hypoalbuminemia can worsen it. So doctors, now let's move to the clinical features of non-cardiogenic pulmonary edema. Clinical features of non-cardiogenic pulmonary edema. The patient will have dyspnea, shortness of breath. The patient will have low oxygen levels, yes. Usually, you realize that there's bilateral alveolar infiltrates on chest x-ray. All right, you'll see that. But then there will be no signs of heart failure. So when you check the JVP, it's normal. There's no S3 gallop. There is no peripheral edema. This should tell you that this pulmonary edema is not as a result of a cardiogenic pulmonary cause. So you see a patient with pulmonary edema, but no increased JVP, no S3 gallop, no peripheral edema. That should cause you to think, okay, this is not from cardiogenic cause. And so you have to start asking yourself, did the patient have a trauma? Did the patient hit the head? If you pick it up, yes, patient hit the head, then that means that is neurogenic pulmonary edema. Was the patient on a mountain? If yes, then you're thinking about HAPE, high altitude pulmonary edema. Did the patient just receive blood transfusion? If the answer is yes, then think about TRALI, transfusion-related acute lung injury. Was this patient exposed to any drugs like opiates, like salicylates? Then you're thinking about it. So this is how you build it up. Number one, patient has pulmonary edema. You check, is there any elevated JVP? No. Is there any pedal edema? No. Is there any S3 gallop? No. Okay, then it could be that this pulmonary edema is as a result of non-cardiogenic pulmonary edema. And then you start asking the questions. So what will be your diagnostic approach? First, you have to rule out cardiogenic pulmonary edema. So you want to check your BNP, brain natriuretic peptide, because in cardiogenic pulmonary edema, BNP will be high. But in non-cardiogenic pulmonary edema, BNP is normal. You want to do your physical exam, check the JVP. In cardiogenic pulmonary edema, JVP will be elevated. In non-cardiogenic pulmonary edema, JVP will be normal. You want to do an echocardiography. In cardiogenic pulmonary edema, echocardiogram will be abnormal. In non-cardiogenic pulmonary edema, echo will be normal. And then you want to do your pulmonary wedge pressure, but that's very invasive. In cardiogenic pulmonary edema, pulmonary wedge pressure will be elevated. In non-cardiogenic pulmonary edema, pulmonary wedge pressure will be normal. Doctors, did that make sense, please? Did that make sense? We are building up. We are building up. That's what I'm saying, that please, if you've not gone for some orange juice or some water, please go get it, because we are not done with the class at all. We are not done with the class, please. We are not done with the class. I need you to stick with me. We are not done with the class. We are not done with the class at all. So if you've not gotten some water or some orange juice, I don't want you to collapse. Okay? So wake up, wake up, wake up, wake up, wake up. Pulmonary cardiogenic versus non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema, BNP is elevated. Non-cardiogenic pulmonary edema, BNP is normal. Cardiogenic pulmonary edema, JVP is elevated. Non-cardiogenic pulmonary edema, JVP is normal. Cardiogenic pulmonary edema, echocardiogram may be abnormal. Non-cardiogenic pulmonary edema, normal echocardiogram. Pulmonary wedge pressure, elevated in cardiogenic pulmonary edema. Pulmonary wedge pressure, normal in non-cardiogenic pulmonary edema. Okay, so after that, you just have to go through what did the patient do? Did the patient go on a hill or on a mountain? Did the patient hit the head? So those other answers will then help you to know the exact cause. So did the patient just have thoracocentesis? Then that is re-expansion edema. Did the patient just have blood transfusion? Then that is transfusion-related acute lung injury. So this is how a patient with acute respiratory distress syndrome, their lung will look like. It is bilateral. You see the infiltrates bilaterally, severe hypoxia. There's a known trigger, for example, sepsis, for example, pneumonia, for example, aspiration. What is Dr. Joanna De Cruz saying? She said, it's always magic in your class. Yeah, doctor, don't worry. We love doing this, and I love studying for you. So no worries about that. Okay, good. So this is the X-ray of a patient with acute respiratory distress syndrome. So what's the treatment for non-cardiogenic pulmonary edema? What's the treatment? Because, you know, in your MCQ1 exam, you always have to learn this clinical features of the condition, investigations, management, complications, indications for referral. So clinical features. So every condition you are dealing with, clinical features, and we've done that. Investigations, management, and if the management fails, complications. When the complication occurs, what are the indications for referral? These are the prongs on which you want to study. So now we are getting to the treatment of non-cardiogenic pulmonary edema. You've got to give supportive oxygenation. Give your intranasal oxygen. give high flow oxygen. So intranasal oxygen does not work, go to high flow oxygen. High flow oxygen does not work, go to CPAP or BiPAP. CPAP or BiPAP does not work, go into intubation if necessary. Avoid overloading the patient with fluid. So be careful with fluids. You only give diuretics in cardiogenic pulmonary edema because diuretics will not usually work in non-cardiogenic pulmonary edema. The only time you will see somebody giving diuretics in a patient with non-cardiogenic pulmonary edema is if there is a cardiogenic pulmonary edema component associated with it. Then, if the patient, so after you've given, so look at the way we are going about it. The patient has non-cardiogenic pulmonary edema. We give oxygen, right? Whichever way we are going to give it. We want to be careful with fluid so that we don't overload the lungs. And then we will hold on with diuretics, but we will only give diuretics in non-cardiogenic pulmonary edema if there's a cardiogenic pulmonary edema component. Then don't forget that in non-cardiogenic pulmonary edema, we know that there are some specific things which can cause it, like trally, like hip, like an infection, like the patient hitting the head or something, right? So then you go ahead to treat the underlying cause. So if there's acute respiratory distress syndrome, which is the commonest cause of non-cardiogenic pulmonary edema, you do your ventilatory strategy and you put the patient in a prone position. If the patient developed the non-cardiogenic pulmonary edema as a result of blood transfusion, what you need to do is to stop the blood transfusion and give supportive care. If the pulmonary edema is as a result of pulmonary then you want to give your anticoagulation or do your thrombolysis. If the non-cardiogenic pulmonary edema is as a result of high altitude pulmonary edema, then what you want to do is to give your oxygen and get the patient from that mountaintop down. And then you can also give another medication called nifedipine. So high altitude pulmonary edema, how will you manage it? Give oxygen, bring the mountaintop, and give nifedipine. Okay? If there's negative pressure, give airway relief. If there's re-expansion, for example, you put in a chest tube, and then you took the chest tube out, and after that the patient developed pulmonary edema, think about giving supportive oxygenation. If there's pulmonary veno-occlusive disease, then the patient will ultimately need lung transplant. And if it's as a result of a toxicity, then what you want to do is to treat the overdose and give an antidote if applicable. So if the patient developed the pulmonary edema as a result of opioid use, treat it with what? Narcan, naloxone, opioid overdose, treat it with naloxone, and then give whatever antidotes you need to give further down the line. What's the prognosis of non-cardiogenic pulmonary edema? Most cases of non-cardiogenic pulmonary edema will resolve on its own within 2 to 48 hours. But in cases of acute respiratory distress syndrome and PVOD, they may take longer. And usually the prognosis is determined by the underlying disease. So for example, we said the PVOD, the patient may need lung transplant, right? So the prognosis is not very, very good. Meanwhile, if somebody developed pulmonary edema as a result of opioid overuse and you've given your naloxone and the patient is getting oxygen, you know that the patient is going to do well. Now, this Dr. Sari is asking a very interesting question. He says, Doc, how do I get the patient down? You got to get the patient down. Get a patient down. Call rescue team to get a helicopter and get the patient down as quickly as possible. Get a patient down from the mountaintop if there is HAPE. That is high altitude pulmonary edema. So, quick summary point. If you see a patient with acute dyspnea plus bilateral infiltrates, the BNP is normal, and the cardiac exam is normal, doctors, please think about non-cardiogenic pulmonary edema. Doctors, please, did the class make sense? You have a patient, okay? Let me say it again. You have a patient who has acute dyspnea, bilateral infiltrates on X-ray, normal BNP, normal cardiac exam, please think about non-cardiogenic pulmonary edema. So let's do a quick memory game for non-cardiogenic pulmonary edema right now. Quick memory game. Quick memory game. Guess the trigger. A patient had pulmonary edema and there is acute respiratory distress syndrome. What is the trigger? Please give me 2 triggers. Give me 2 triggers. Quick. Give me 2 triggers. Give me 2 triggers. Quick one. Give me 2 triggers. And by the way, doctors, please don't forget to click on the like and the subscribe button. Give me 2 triggers. 2 triggers of acute respiratory distress syndrome. We are not done with the class, please, so don't run away. Give me 2 triggers of acute respiratory distress syndrome. 2 triggers of acute respiratory distress syndrome. Acute respiratory distress syndrome. 2 triggers. Beautiful. Sepsis. What else? And trauma. Acute respiratory distress syndrome. Sepsis and trauma. Sepsis and trauma. Sepsis and trauma. Sepsis and trauma. What about pulmonary edema plus HAPE? What is that? Pulmonary edema plus HAPE. High altitude pulmonary edema. That means that the patient climbed a high mountain. Okay. What about Trally plus pulmonary edema? What was the trigger? Trally plus pulmonary edema. What is the trigger? Trally plus pulmonary edema. What is the trigger? Trally plus pulmonary edema. What is the trigger? The trigger is blood transfusion. Beautiful. What about re-expansion edema plus pulmonary edema? What's the trigger? Re-expansion edema plus pulmonary edema. What's the trigger? What's the trigger? Please, doctors, tell me something quick. Re-expansion edema plus pulmonary edema. The answer is thoracocentesis, right? You did thoracocentesis. Okay. What about drug-induced leak plus pulmonary edema? Drug-induced leak plus pulmonary edema. Drug-induced leak plus pulmonary edema. What's the correct answer? Or give me some 2 common drugs. Common drugs, which can lead to drug-induced leak plus pulmonary edema. Beautiful. Opioids and salicylates. Opioids and salicylates. Okay, so let's look at a summary table about differences between cardiogenic and non-cardiogenic pulmonary edema. Summary table. What's the mechanism? In non-cardiogenic pulmonary edema, there's increased alveolar capillary leak. But in cardiogenic pulmonary edema, there's hydrostatic pressure, which is increased. What about brain natriuretic peptide? In non-cardiogenic pulmonary edema, brain natriuretic peptide is normal. In cardiogenic pulmonary edema, brain natriuretic peptide is elevated. What about JVP? JVP. In non-cardiogenic pulmonary edema, JVP is normal. In cardiogenic pulmonary edema, JVP is elevated. What about S3 gallop? S3 gallop. In non-cardiogenic pulmonary edema, S3 gallop is absent. But in cardiogenic pulmonary edema, S3 gallop is often present. What about peripheral edema? In non-cardiogenic pulmonary edema, peripheral edema is absent. In cardiogenic pulmonary edema, peripheral edema is common. What about wedge pressure? In non-cardiogenic pulmonary edema, wedge pressure is normal. In cardiogenic pulmonary edema, wedge pressure is elevated. So the bottom line is this. In a patient with normal BNP plus no heart failure signs, think about non-cardiogenic pulmonary edema. Doctors, now is the time for your quiz. Active recall. Active recall. But doctors, before the active recall, why do we do this? Why do we struggle every Sunday to bring this to you? Doctors, we want to make sure that you're able to ace your exam. And that is why I'm putting in all these efforts. So ask yourself, even if this is the free class, what is actually happening in the paid class? So there's the opportunity for you to work with us, in our paid community. And I see a lot of our candidates here, Dr. Joanna De Cruz, Dr. Asari Joseph, Dr. Rockefeller, all of them are in our program. Okay. Now, in the program, you're going to get lectures like this. So tonight, those in the program, and if you want to join the program today, you can. You're going to have a class tonight. Every Sunday evening, every Thursday evening, you have a class. You also have an online portal where your lessons are loaded. And even if you miss a class, that class replay is loaded in your portal. You have a question bank in your portal as well. And you can try some mocks on your own. We also have what we call med bullets. Med bullets is like, the way you're able to make your final revision notes for your exam. MedCognito says, don't worry about that. We've already done that for you. It's in our family medicine portal. Go there and start reviewing concepts. And then every 2 weeks, we conduct a mock exam, which is live. And Doc, you have all this for just $420 every month. Or if you want to pay for 6 months straight, you get a discount of about $350 and you pay just 2,200 Canadian dollars. Okay, this is all for you. The truth is that prices are changing in January because in January we are upping our game again. So if you think we are giving a lot of value, in January it's even going to be crazier. So if you want to jump on, this is the time. I'm just telling you, this is the time. Okay, this is the time. For just 2,200 Canadian dollars, you get access for 6 months straight, one-time payment. But someone will say, Dr. Bonnie, I want to pay monthly. That's fine. You can do that monthly with your credit card, just $420 every month. Okay, and I'll be dropping the link in the comment section while we do our active recall. So if you want to join the class right now, this is the opportunity to do so. This is the opportunity to do so. This is the opportunity to do so. So people have already started sending me messages that they want to join the class right now. Sure, I'm sending the link to you right now. The link will be in the comment section on YouTube, on Facebook, and those who are also sending me a message privately, I'm going to send you the link right now as well. So please, this is the link. Okay, good. You can use the link to do the registration. And someone just connected with me. I've sent the link right now. Okay, so now let's go into our active recall concepts. Active recall concepts. Number one, what are the core differences between cardiogenic and non-cardiogenic pulmonary edema? What are the core differences between cardiogenic and non-cardiogenic pulmonary edema? I'm giving you just 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I see so one has increased left-sided filling, which is increased wedge pressure, and then one that has normal wedge pressure. So cardiogenic pulmonary edema has increased left-sided filling pressure. Non-cardiogenic pulmonary edema has increased alveolar capillary permeability. All right, good. Next one, 3 precipitants of flash pulmonary edema. 3 precipitants of flash cardiopulmonary edema. 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 3 precipitants can be hypertensive emergency, acute ischemia, and new tachyarrhythmia, as well as obstructive valvular disease. Okay, good. Next one, a tool that definitely separates cardiogenic from non-cardiogenic pulmonary edema. When you are uncertain, what tool will you use to help you to separate between cardiogenic from non-cardiogenic pulmonary edema when you're not sure? This is what I'm giving you, just 5 seconds. 1, 2, 3, 4, 5. Come on. So you have to directly measure pulmonary capillary wedge pressure. So direct measurement of pulmonary capillary wedge pressure. Okay. You can also do your echocardiogram. Now, what major mechanisms distinguish cardiogenic from non-cardiogenic pulmonary edema? What major mechanisms distinguish cardiogenic from non-cardiogenic pulmonary edema? I think this question is a bit vague, so I'll give you the answer. Cardiogenic pulmonary edema, there's increased hydrostatic pressure from elevated left-sided cardiac filling pressures. And non-cardiogenic pulmonary edema, there's increased capillary permeability, right? We've gone through this over and over and over again. And remember Pickering syndrome, right? We learned about it, where the patient has bilateral renal angle stenosis, and that leads to recurrent pulmonary edema. That's Pickering syndrome. Now, what is the most common cause of non-cardiac pulmonary edema? What's the most common cause of non-cardiac pulmonary edema? This one I'm giving you just 5 seconds. 1, 2, 3, 4, 5. I'm giving you just 5 seconds. ARDS. That's the correct answer. Acute respiratory distress syndrome is the most common cause of non-cardiac pulmonary edema. Next question. Name 5 drugs or toxins that can cause non-cardiac pulmonary edema. 5 drugs or toxins that can lead to non-cardiac pulmonary edema. I'm giving you 5 seconds. 1 second for each drug. 1, 2, 3, 4, and 5. Okay, so I see some answers. Opioids like heroin, methadone, fentanyl, salicylates, amiodarone, immunosuppressants like sirolimus and everolimus, and vaping products. Okay, and then I have a question for you. Yes or no? Does hypoalbuminemia alone cause non-cardiac pulmonary edema? Woo! Dr. Musima and Dr. Asfia, all of them say no, 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 no. Hypoalbuminemia alone does not cause non-cardiogenic pulmonary edema. It only worsens edema if pulmonary capillary pressure is on the rise. Okay, good. Which condition causes unilateral? Oh, I gave the answer away. Unilateral non-cardiac pulmonary edema. It is re-expansion pulmonary edema. Okay, after there is thoracocentesis or pneumothorax, drainage, or removal of an obstruction. Okay, good. Now, what clinical features makes non-cardiogenic pulmonary edema different from cardiogenic pulmonary edema? What clinical features makes non-cardiogenic pulmonary edema different from cardiogenic pulmonary edema? What clinical features makes non-cardiogenic pulmonary edema different from cardiogenic pulmonary edema? And the answers are: no JVP is elevated in the non-cardiogenic pulmonary edema, no gallop rhythm, no peripheral edema, normal wedge pressure, and normal brain natriuretic peptide. What viral infections can cause rapidly progressive non-cardiogenic pulmonary edema? What viral infections can cause rapidly progressive non-cardiogenic pulmonary edema? What viral infections can cause rapidly progressing? Beautiful. Coxsackie. I see that. So Coxsackie virus, we also have hantavirus, Ebola virus, enterovirus, dengue hemorrhagic virus, fever, and I have to add Coxsackie as well. Okay. What's the most important diagnostic step when evaluating suspected non-cardiogenic pulmonary edema? What's the most important diagnostic step when evaluating suspected non-cardiogenic pulmonary edema? What's the most important diagnostic step when evaluating suspected non-cardiogenic pulmonary edema? So Dr. Mosima, beautiful, he says, rule out cardiogenic pulmonary edema. And how do you rule that out? You do your clinical exam, you do your brain attractive peptide, you check your echocardiography. Okay, good. So doctors, that is my phone number. And I know that after this class, my phone is going to buzz. So if you want to speak to me, dial my number right now and call me right now, because after a few minutes, I'm going to put my phone off and go spend family time, right? So doctors, today's class was about pulmonary edema. We also did case fatality rate. So today you have 2 videos you need to go and review on the YouTube channel. Make sure you share these videos with your friends. Make sure that you are studying and you review these concepts. My phone number is +1 306 891 5649 +1 306 891 5649. I prefer WhatsApp messages because if you're outside the country, then I can call you. Doctors, it's always a wonderful privilege for me to spend my day with you. And thank you very much for participating in the class. And I hope that the class was helpful. I have a question. So please, if you want to reach me right away. Are you okay with the way we did the first session and then we added the second session to it? Are you okay? Is there anything we should do to improve our sessions? Please talk to me. Are you okay with today's session? And is there anything I can do to make the sessions better? Are you okay with it? Okay, good. So doctors, those who want to reach me, please reach me now. Those who want to sign up right away, please use the link I'm sharing in the comment section right now to join the course. It's very self-explanatory, but if you want me to walk you through it as well, I'll be very glad to do that. Okay. Thank you very much, doctors. +1 306 891 5649 +1 306 891 5649. Thank you very much. Have a wonderful day. Bye-bye.